Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep those succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you that all your comments will remain accessible online as the meeting recording remains on the council's website. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Allen, Councillor Kendrick, Councillor Parkin, Councillor Welbury, Councillor Morgan, and we've also received an apology from Councillor Woolley, Executive Councillor, NHS Liaison, Integrated Care System Registration and Coroners. Thank you, Chairman.
Thank you, Trina. In which case we'll move on to agenda item 2, declarations of members' interest. This is an opportunity for members of the committee to declare any pecuniary or other interests. Do members have any interest to declare at this particular point? No. Should anything arise throughout the meeting, then feel free to raise and we will ensure we get those down. We'll now move on to agenda item 3, the minutes. This is to confirm the minutes of the meeting held on the 20th of March 2024 as a correct record. They are found on pages 3 to 12 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these on block. Is there a proposer? Thank you, Councillor Mackinson-Saunders. Seconded, please, Councillor Smith, and all those in favour, please show. Thank you. That's supported. Any against? An abstention. Thank you, Councillor Hayes. They're carried. I'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda. There are no supplementary announcements for this meeting. Additional information from LPFT from the last meeting is still awaited. Do we have any questions, please? Councillor Smith.
Thank you, Chairman. It's not so much a question, more of a statement on 2 of the items in your announcements. With respect to item 2, personally, I think we need to keep a very close eye on this, as there's 2 schools of thought. This could be a move to reduce time taken up by more senior clinicians on certain tasks to free up their time, or it could be further de-skilling. I don't know which it will be, Chairman, because it's not happened yet, but I think only time will tell. But I think we need to watch that very closely. And secondly, Chairman, around the national objectives that the NHS has for this coming year, again, I think it's very much a very close watching brief because I'm still very much aware of in excess of 7-hour waits in A&E. I'm aware of that only last month at Lincoln County for somebody I know. It was a member of their family, I believe. So again, whilst they're there and they need to be there, I think it's a case of are they actually being achieved, and are they progressing, or is it that's just the objective because that's what we need? So again, I think it's very much a case of watch and step in as we can if we need to.
Yeah, thanks, Councillor Smith. We will, of course, with everything, keep an eye on that. And, of course, we do have an item on urgent care coming up later, so any concerns can be raised at that point. Are there any other questions on my announcements? No, in which case, do we have a proposer to note these, please? Thank you, Councillor Mackinson-Saunders. Seconded, Councillor Smith. All those in favour, please show. Thank you. They're supported. In which case, we'll move on to agenda item 5, NHS Dental Services in Lincolnshire. This item was circulated as part of the agenda pack on pages 21 to 42. The committee has been receiving regular updates on NHS dental services as access to the NHS dentists continues to be a concern. And I'd like to welcome our presenters in person. We have Sandra Williamson, Director for Health Inequalities and Regional Collaboration for the NHS Lincolnshire Integrated Care Board. Sarah Starbuck, Head of Primary Care Commissioning and Development. Kenny Hume, Chair of the Lincolnshire Local Dental Committee. And the East Midlands team, we have Caroline Golding, Head of Primary Care Services for the East Midlands. Katriona Peterson, Associate Medical Director for Dental. And Anna Ireland, Public Health Dental Consultant for NHS England. I'd now like to hand over to you for the presentation, if you can do that in around about 10 minutes, and we'll take questions at the end. Thank you.
Thank you, Chair, and thank you for inviting us to provide an update. The last time we
Sorry, I
met-
should say, with any of the speakers, if you bring the microphone close to your mouth.
Can you hear
Thank
people
you.
here?
Yeah,
Oh,
I can hear
that's
you
okay.
perfectly. Thank you.
Thank you for inviting us for an update. The last time we met was back in July 2023. I'll just do by way of introduction, and then I'll pass to my colleagues to give an update. But as in many parts of the country actually, the access to NHS dental services in Lincolnshire still remains a challenge. So as part of our previous update, we remain a commitment to improving access and providing high quality dental care. We talked about the last time we met about the dental strategy, so part of the update today will be about how that is progressing in terms of an implementation, and as well the support of the National Dental Recovery Plan. We also mentioned at the previous discussion the commitment to the development of the Centre for Dental Development. So I'm pleased to say that the work has started to progress with that, working with University of Lincoln and with partners across Lincolnshire to look at the co-design and development of the Centre for Dental Development, which we'll be able to touch on a little bit further in the discussion. So the detailed paper, we won't be going through in any detail, but it is there for information that you've received as part of your pack. First part of the discussion will be about dental strategy, the developing the workforce and increasing focus on prevention. That will be taken through with Katrina and Kenny. We'll then move on to a discussion around the improving access and the dental recovery plan, both in terms of our dental strategy and the national, and that's where Caroline will be able to provide an update on that, and then we'll be happy to take any questions. So I'll start with Katrina first, if that's okay.
Thank you. Thank you, Sandra. It's recognised that one of the barriers that dental providers face in trying to complete their UDA contract is recruiting a workforce who are willing to perform on the contract. Not only do we need to be able to recruit more dentists and therapists to fill the spaces, but we also need to keep the ones we have. As explained later by my colleagues and in the report provided prior to this meeting, steps are being taken to make the contract more favourable, and work is ongoing on this, but it is a national contract, so most of the changes are coming from the national team. Caroline will talk about this a little bit more later. The plans for the Centre of Dental Development in Lincoln, which as Sandra say are now progressing, include a training hub, which hopefully will provide the peer review and support the dental teams in the county currently lack. Currently support...
I had a bad day yesterday. I did. I was going to ask you, that was my next question.
Sorry, it's out. Sorry. The plans for the Centre of Dental Development in Lincoln include a training hub, which hopefully will provide the peer review and support the dental teams in the county currently lack. Currently, support with complex cases needs to be sought, as I'm sure you're aware, from further afield. But we hope to be able to bring this support into Lincolnshire alongside training our teams within the county. We hope that this will lead to better retention long term if we grow our own. It's recognised that during the COVID period, the GDC Overseas Registration exam was paused. This is now up and running again, and the numbers sitting the exams has been increased, but it still remains a lengthy process, often taking up to 5 years to complete. These dentists who are completing the ORE are already qualified overseas, with some with many years of experience, so innovative ways of enabling them to perform dentistry under supervision whilst completing the registration process is currently under consultation. We already have a number of these overseas dentists working in practices in Lincolnshire as DCPs, and we hope as soon as the legislation is put in place, we will be able to upgrade them to dentists working under supervision under the provisional registration. There are other plans in place, talked about in the Dental Recovery Plan and the Long-Term Workforce Plan. These are national schemes, but it's recognised that Lincolnshire is an area of great need on workforce, so we are being prioritised as much as we can. There's an expansion of the dental undergraduate training places with a 24% increase in places by 2028. This is being done, or anticipated that it'll be done within current dental schools, but these dental schools will need to place the undergraduates out in the community to gain hand-on experience, as they don't have enough space in their own facilities. We have identified the Centre of Dental Development in Lincoln would be able to accommodate some of these placements. There's a consultation planned for the spring with regard the tie-in of NHS undergraduates to carry on working in the NHS for a number of years. There's an increase in the number of dental therapists and other dental care professionals. It's been suggested a 40% increase nationally by the year 2031. This will help once they come into practice in delivering on the contract if they're working within the NHS. Similarly, for the therapists, there is a consultation which was held last year, which has agreed that the human medicines regulations of 2012 will be adjusted to enable hygienists and therapists to supply and administer specific medicines without the need of a sign-off for a dentist. This will improve their workflow and should therefore increase their activity on the contract. As I touched on at the beginning, the provisional registration that is being put in place is out to consultation at the moment. That consultation finishes on the 16th of May, so hopefully things will progress once that's completed. Department of Health and Social Care are currently inviting comments to this proposal, and you will be able to find it online if you would like to make comments on the proposal. All of these proposals require the dental team to be supported whilst they first start working in practice. We are working closely with NHS England Workforce Training Educational Director to increase our support in Lincolnshire. So far, we have put in place extra mentor courses. We've introduced flexibility to work-based supporters' requirements so they can now mentor more than one trainee at the same time if we feel they have capacity. There is a training program director who has been specifically tasked by the Workforce Training and Education Department to engage with practices and understand their needs and the barriers they are currently facing, so that we're feeding that back to the ICB, or they're feeding it back to the ICB, so that the ICP can look at ways of supporting the practices. And we're also in the process of putting a clinical fellow into a practice in Lincolnshire, which currently is not a training practice, but they're going to work together to develop themselves into a training practice. I've touched on many different items there. Hopefully that'll give you a bit of a flavour of what's happening. Thank you.
Thank you. Thank you. I hope you can hear that. Yeah. Thank you, Katrina, for that comprehensive report. Katrina touched on a lot of things that is part of my report as well, so I won't repeat myself. Prevention is a key component of the dental recovery plan. I hope you would all agree with that prevention, dentistry in primary care is very much a reparative service. We repair, we don't prevent, and part of that is to do with the way the contract is as well. Conveniently, yesterday we had the Oral Health Advisory Group, which is chaired by Lucy Gavins, who most of you will know. Conveniently, Lucy said, if there's any questions or any sort of points about prevention, just refer to her out of this meeting. So I've sort of got away with it, if you know what I mean. We are doing a lot of what was mentioned in the dental recovery plan is already happening in Lincolnshire and more. We have a well-developed Lincolnshire Smiles programme, which involves members of the community dental services going out to schools and difficult to access areas, particularly in the East Coast, and going into schools. And that programme is developing. We're working with the dental hub of the ICB, looking at apprenticeships, looking at oral health practitioners and the like to deliver a preventative service. And of course, from a cost point of view, prevention is a far more effective way of using your money than repair. So that I feel is a key point. Fluoridation is high on the agenda. That's now a national issue rather than a local issue, as you're aware. The east of Lincolnshire is unfluoridated. the west is. The decay rates on the east are significantly higher than on the west. And if you look at areas like Boston, I think there is one ward in Boston that's bottom 10 of the whole country, really. So that is an area that we're focusing on. And a lot of the stuff that we do is very targeted. We're targeting in areas of deprivation. We're targeting in areas where we know that the decay rates are high. I think that's probably everything that I can say on prevention. And just to say that we have talked, dentistry is getting you know, it's in the media, it's everywhere just now, but there are lots of really positive things going on within Lincolnshire. Katrina and Sandra have highlighted that. We're doing a lot. We recognise the situation, but we're doing a lot to try and rectify that situation. I'll keep it brief. Thank you.
Thanks. The area I wanted to update on is the access initiatives that were announced as part of the dental recovery plan and how that overlays into Lincolnshire. I will also bring in my colleague who's remote, which is Anna Ireland, one of our dental public health consultants, because she's been leading the work to refresh our primary care oral health needs assessments, and we can talk about some future plans. So as part of the announcement from central government, there was specific asks to move to improve access to dental services for patients, and this was across the country. So some of the areas that we correlated was that we're having a lot of patients come to us to say they can't access services as new patients. Not that they are not remaining with practices, but they are struggling to access new practices. So one of the things that central government decided to do was to have a look at how we can support practices to increase their uptake of new patients. So they have introduced a new patient premium where practices will be supported to take on new patients, to complete assessments and to complete treatment on new patients. For Link, there were some quality standards and some performance standards we had to apply. So if a practice isn't performing to where they should be on a contract, then we are not enabled to allow them to take part in that. But for Lincolnshire, we have a total of 51 practices within our system, 47 of them qualified, so we have 92% of our practices being able to support new patients. Now, this is the second month of this support and initiative, so I don't have the data to actually say how we think that is landing, both with the profession and how that is working with patients. What I would hope, Chair, is that at our next update, we would be able to give you some further details and data to see actually how that support is being mobilised and how that is impacting patients. So at this moment in time, I can't give you how that's working, but I will continue to work with Healthwatch really closely to see if we are making an impact. The other area, and I know in previous updates there's been a lot of talk about the general discontent with the National Dental Contract. A key element of that discussion is that the financial value that is placed on a unit of dental activity is not financially sustainable within the current financial context. So some of the work that nationally they are looking at is they are looking to uplift the UDA level. Now, for this last recovery, for this last announcement, the central government said that any practice that was remunerated at below £28 per UDA would have an increase into their contract. Now, for Lincolnshire, that we had to apply certain standards. So for practices that were retrieving contract value and value for money, that we could consider that. Within that piece of work, contractors could ask either to increase their contract value or reduce their units of dental activity to increase their minimum baseline. I'm pleased to say that the majority of our practices did take the increase, so we didn't lose many UDAs, and actually that resulted in an increase of investment from the ICB of £450,000. So we will be really closely monitoring them, because that is one of the key aims. Now, to be very transparent, that isn't about transforming services, that is about retaining what we currently have. So to be clear, we will be able to track the progress of those practices to see whether this does impact contract terminations. As you may be aware, in previous updates, we have had a number of contract terminations. That has slowed at the moment, so I think we are waiting to see the impact of the National Recovery Programme to see whether we can continue to retain and then build on what we have. The other element that actually brings a sharp focus to Lincolnshire is that Lincolnshire was one of 12 systems that were identified that had acute dental care shortages, and as such were prioritised for dental vans. Now, within the East Midlands area, both Lincolnshire and Northamptonshire were identified as key systems that we had to rapidly mobilise services for. So we have created and started mobilising a joint workforce between ourselves in Lincolnshire and Northamptonshire to work together to maximise synergies. The premise of the vans will be that they will complete bands 1, 2 and 3 work. We have identified areas of need within the county where the vans will need to be placed, because we have to identify those needs, and we are currently working with the local providers to understand how quickly and rapidly we could mobilise. It will be increasing. It is a very clear ask from central government that it's an additional service, and we are working with current mobile services to see how we can create the additionality of it. We are under a lot of scrutiny from central government and national team on this, and it is a key aspect of my delivery and my team's delivery to mobilise a service. I would hope that by the next time we are asked to attend HOSC, that we will provide a further update on our mobilisation on that programme. The other area to say that which does support Katrina and Kenny's update is Golden Hellos, so incentives to retain workforce. Now, previous to the National Recovery Plan, we already had this in place, so we went ahead of the National Recovery Plan, and I am pleased to say that some of the work that's been included in the National Recovery Plan was adopted from the work we've done in Lincolnshire. So we are still offering Golden Hellos and support for workforce to remain in Lincolnshire. As much as this is all positive news, I have to say the access to services is still stark, but I will say that we are working as hard as we can, firstly to retain what we have, so we have a good baseline to then transform. I'm going to bring in my colleague who's remote chair, Anna Ireland, we are just finalising our oral health needs assessment. Now, this document has been refreshed since the pandemic, and it clearly highlights our most area of need. And now the plan going forward, Chair, is that we have a number of budget allocations that we have been able to protect and retain within Lincolnshire for dental services. But what we wanted to do is we wanted to deploy that unallocated budget to where the need is. Not where we currently have practices, but where the need and the population is. So Anna's just about to complete that work for us, and we will start then progressing that document through our governance, through the NHS governance, and then we will start deploying a commissioning plan, which we can give further updates to, Chair, so we can be really clear that where we are deploying additionality of service. So I'll pause there.
Hello, I will speak briefly because Caroline's updated quite a lot for me. So as she said, I've been updating the oral health needs assessment for Lincolnshire. It's a follow-up needs assessment to a rapid needs assessment that was carried out about a year ago. And that rapid needs assessment particularly asked for a focus on primary dental care, delivery, access and commissioned services. And the oral health needs assessment follows a framework that we have agreed with all the ICBs in the East Midlands and the local authorities. So this is one of 5 needs assessments that I'm doing across the patch. It's, as Caroline said, going to be one of the sources of information that the commissioners can use in developing a commissioning strategy. And in it, I have used the most up-to-date full year data that I can get hold of. And I have particularly looked at things like which type of patients are accessing care, both new patients and existing patients, how often they're being seen, where they're being seen, that kind of thing, how long they're having to travel. And at the moment, as Caroline has said, the findings, conclusions and recommendations are not in the public domain because it's still going through the governance process. So I can't discuss them here at the moment, but I'm happy to come back at a future date and do a fuller summary for you if you would like. And just very briefly, while I've got your attention, I just want to build on what Kenny said with water fluoridation. So as he mentioned, half of Lincolnshire is fluoridated at the moment, but the other half isn't. And the half that isn't is where we have the highest oral health need at the moment. And I'd just like to draw your attention to the fact that we have going on at the minute a national consultation on expanding water fluoridation in the northeast of England. And I would urge people to look at that consultation and to respond, because this will be a bit of a determiner about whether any future expansion happens in England. If the decision is not to expand in the northeast, then I think probably it'll be tricky to expand into other areas. And I know that some stakeholders in Lincolnshire are keen to see an expansion of water fluoridation into these. So I just urge you to look at the consultation and to respond and to circulate it within your distribution groups and things like that. I'm happy to take questions on the needs assessment if you would like, but I will end my summary there.
Okay, thank you. Carol?
And the last update, obviously in previous attendances here, we gave some operational updates and some key pieces of work. So the team are continuing to mobilise the new dental service out in Mablethorpe. It has been slightly more challenging than we'd hoped, and there is a couple of tricky legal points because of change in legislation that we couldn't foresee. However, so that's delayed the start of the service. However, we are hoping to resolve them rapidly within the next 3 to 4 weeks. However, to make sure that we still have the urgent service out there for patients on the East Coast, we have still commissioned what we already had in place. So there isn't a gap in services. We've still remained with the urgent care service. It's why we just finalised the last points of legalities that we couldn't foresee. We have just extended our community dental services contract because we see that contract as a key contract to the delivery of dental services across Lincolnshire for our most in need patients. So we will still be working with the providers for another 3 years. We are hoping that we would then look at what our longer term strategy is. We currently have, where we've had some significant handbacks on the East Coast, we have commissioned urgent dental care. So we may not have been able to commission primary care, but we have recognised that we need to have an urgent care service out there while we deploy a longer term commissioning strategy to get more dental workforce into that area. And we continue to work really closely with Healthwatch because obviously we are aware this impacts patients at every level in every ward across the county. So we are proactively working with them to make sure our education and our communications are as supportive as possible while we work as rapidly as we can to improve services.
Okay, thank you. Questions? Do I have any? Councillor Smith first, please.
Thank you, Chairman. Some of the points have been answered, so I shall phrase my questions in a slightly different way as I was intending to. Without wishing to sound like a stuck record, Chairman, if you note figure 2 at the bottom of page 30, as Councillor Allen and I have mentioned in the past, and the national picture isn't much better to Lincolnshire. Basically, the long and story short is, Chairman, 75% of the population do not have a dentist, that is, an NHS dentist. So what are those 75% doing? Because most of them will not be able to afford private dentistry, Chairman, which means, say it's a conservative estimate, say 15% can. That means 65% of our residents across the piece don't have access to a dentist, which is quite alarming in this day and age, Chairman, and what that will lead to is basically 2 generations where we're going to have an endemic dental crisis potentially. Because I can remember a story many moons ago, and I was in the south of England at the time, and people were resorting to DIY dentistry with pliers, and I know very much that still goes on, in fact more so now than it did at the time. Secondly, Chairman, and whether the presenters can answer this, I don't know. What work is being done on a national level around how UDA is calculated? Because to my mind, Chairman, that is when things start, that is when the issue started, is when the contract was changed in 2006 and the UDA rate was changed. And because it used to be, if you extracted 2 teeth, the dentist was paid, you took 2 teeth out, you were paid for taking 2 teeth out. Then it went to UDA, and then after that, we saw an exodus of NHS dentists who basically said, this is costing me, it's actually costing me money to run, I can't afford to do it, I'm going to go private because I'm actually not being given a fair whack, if you like, for what I'm doing as a qualified individual. So I don't know if the presenters can answer what work is being done around a more longer term solution. I know we've talked about bits around the side and, as I'd call it, tinkering about the side, and this probably is a requirement of national government, I should imagine, but that really needs a structural reform, because without that, you can tinker around the side, and any system can tinker around the side as much as you like until that problem's fixed. You're going to get contractual handbacks, or you'll get times where they'll work for so long and then say, I've had enough now, which I appreciate is probably beyond your control. But if it's something we can do, what can we do? If it's not, if it's national, I understand that, and I'll take that away. Thank you.
A couple of points. I'll try and answer them. Yes, you're completely right. There is work needs to be done to nationally reform the contract. For the first time in the latest set of initiatives, there was a really clear steer that they wish to reform the contract. I think the difficulty in being transparent is the pace of that reform. We will, and we continue to work as an ICB to help steer those conversations, to help design what we can. The immediate priority for us is to retain what we currently have where we have. So when the reform comes in, we can then build on what we have for the patients. But completely agree, it does need a national reform. One of the areas we are looking at is, and this would have to be a wider piece across an East Midlands patch because of how the dental profession and the contracts work, is we are considering whether we could commit to a longer term plan to increase UDA values across the East Midlands patch. Now, I do get a lot of challenge back in saying, why can't we do that for Lincolnshire and forget the others, and can we do it for another system? The issue is that a lot of the associates work across different geographical boundaries, and we have a lot of contracts that provide services across every system of care. So it's such a strategic view. So that's one of the areas we are looking at and we are actively considering. With regard to population access to dentistry, it's fair to say that the NHS commissioned services have never been 100% commissioned for dental. It's unlike GP, where everyone has a right to GP services. Every system historically has commissioned a certain level of UDA. Now, that does pose us with problems, because it means we have to really consider which population, how the population is served and where our most need is. We recognise the increase in private dentistry, and that has been increased since the pandemic. But what we will do in Lincolnshire, and what we are actively trying to do, is, having listened to patients, a lot of the younger generation are telling us that they don't actually want to go to dentists regularly for recalls, but when they are in pain and they have an acute care need, they want that sorting, they want access to it. So where we are trying to do it in interim, we are trying to shore up our urgent care services to make sure, while we work on the longer term strategy, that we can make sure that there is a good level of urgent care service. But to bring my point and answer to a close, you're right, the dental contract reform does need to have national sign-off. But what I will say for assurance, we are doing everything within our remit, within an ICB, to improve what we can do and influence what we can do.
Just got Kenny, and I've got Anna to come back to your comments, and then I'll bring you back in, Councillor Smith.
Councillor Smith, you talked about UDA values. So when the contract came into being in 2006, the UDA value was worked out historically. At Lincolnshire, fewer dentists, but greater number of patients per dentist. And so consequently, our UDA value is lower than other areas, really. So we started off with a lower UDA rate. Now, with successive pay increases and whatever, then the difference between the UDA rate in Lincolnshire, because 5% of £40, for example, and 5% of £20 is significant in time. And so consequently in Lincolnshire, we were always playing catch up, really. Carlin talked about the UDA rate going up to £28. That's affected 43% of our practices. So that's a significant increase for our practices. Thank you.
Anna, do you want to come in?
Yeah, just quickly. The first thing is the recovery plan did commit the government to consulting on contract reform in 2024 and implementing changes in 25. And that's the first time we've sort of seen it written down with stark dates against it. So governments depending, I suppose, and elections depending, that is a commitment they've given. And then just a quick point on the population accessing care. It's quite nuanced. So one of the things I've done in the needs assessment is picked out access and who's accessing by age, deprivation and location, because it varies. So it's not as simple as saying there's a blanket proportion of the population in Lincolnshire accessing care, because actually it is so variable depending on things like age and deprivation. But that'll be something that'll be pulled out in the needs assessment and you'll be able to read about.
Thank you for allowing me to come back, Chairman. You mentioned a very interesting point that young people don't want regular treatment of younger people. Is that because they've never had it? Is that because they don't know the importance of having it? Or is it purely a choice? Because to my mind, it's not the fact that it's just choice. It's actually they've never had it. So they don't miss what they haven't had. And they don't realise, actually, if I went, even if it was only twice a year, the benefits of going twice yearly, even if it's just for a checkup and a hygienist, are huge. But because they've never had it, they'll never miss it. So when they have a problem, I've got a problem, I've got a tooth that needs removing, or I'm in searing pain, I'll go and see somebody, because they've not actually had that regular contact with the dentist from a young age, or from an age where it's in bed, or however long I need to go and see somebody.
Completely recognise that. I think Kenny or Katrina could come in, because we are doing a huge amount of work regarding the recall, because one of the areas we know within the contract is that patients are coming back for routine checks too often, which then doesn't release capacity for new patients. So do you want to?
I think the figures in the document showed that actually Lincolnshire was slightly ahead of the curve in terms of seeing our children. I can't quite remember, but I do think we are slightly ahead. And the work we're doing in prevention, as I alluded to, going into schools, and that is building. You know, it's debatable if an 18-year-old who has been seen on a reasonably regular basis needs to be seen every 6 months if they've got a low risk. And recalls are based now on risk and risk factors. So it's, you know, someone may have a 6-monthly recall, someone may have an 18-monthly recall based on the risk. And that's correct and apportionate, really.
Anna, you'd like to come in again?
Yeah, the other thing we see in Lincolnshire, but also nationally, is that between the ages of about 18 and 25-ish, something like that, there's a dip in access, in the population accessing care, but that's true for healthcare as well. So that portion of the population are often, you know, just leaving university, they're going on to do new jobs, they feel young and invincible, so that they feel they don't need healthcare in the same way as those of us who are a bit older do. So it's also something about the stage in life that they're at. So it's not necessarily just about whether care is accessible. It's about whether they want it at that stage in life, and often they don't. And quite often it's not until they start getting families of their own, and I suppose beginning to think about their own health and mortality in a different way, that they start re-accessing care.
Okay, thank you. Liz?
Thank you, Chair, and thank you very much for your presentation. I think it's really kind of, we're in a state, aren't we now, where things are starting to improve, although it's not going to be immediate improvements, but there are improvements being made. So for Healthwatch, that's really, really reassuring to hear. And I think what was more assuring to hear some of the actual things that are in place, like the increase in the contracts. And I know, Caroline, you were saying we were already working with ourselves as Healthwatch. In terms of that work, I think the emergency pathway, there's still some confusion about that, and we do have quite a number of patients that voice that to us. So I don't know whether there's any work that we can do together to try and improve the messaging to patients around that, in terms of the links to 111 and then what 111, how they work through that pathway. So that'd be really helpful for the patients. And then just a couple of things. I mean, it's great to hear that things are coming online, but how are we managing the patient's expectations, I guess, and how can we support you with that? That the strategy and the changes won't all happen immediately, and we've still got patients wanting access. So it's kind of, what thoughts have you got around that, and particularly to try and avoid something that happened, I think it was in Bristol, wasn't it, where a new practice opened, then there's people queuing round the corner. So what thoughts have been given to new services coming online, and how we manage and make sure those that are greatest need have got access to those services, rather than it being a bit of a free-for-all? Thank you. So quite a bit in there, but...
Okay. With regard to the new services, so in relation to Mablethorpe, we are actively working with the new provider coming on to manage patients, because we do not want to see the queues of residents waiting outside the new practices. We have set up early telephone lines so patients can contact and get registered before the opening day. We are doing a really soft launch, so we aren't going to come out with lots of... we're not going to do a big PR drive initially. It's going to be very soft, and then once we're confident that everything is working, all the pathways are there, then we will do a bit more. This is a really good news story for the east coast of Lincolnshire. What we have tried, and this is, we do need to do some work, I will acknowledge, we do need to do some education and communication on patients on how they access, and I do recognise we need to do some more work to refine the 111 links, the emergency care pathway. So we'll take that on board, and we can feed that into some of the dental strategy work, because you are a key player, so we do have Healthwatch on our dental strategy work team as well, to make sure that what you is. So we'll take them on board and take them back.
Councillor McGee?
Yeah, with regards to UDA allocation, I understand that it's some of that's based on the need within an area, but do you also base that on population figures?
I'm going to bring Anna in, because the current UDAs we have commissioned was based on historical work. The work that Anna's doing on her needs assessment will then align to our commissioning plan. So Anna, I don't know if you want to pop in and just say about some of the data you've used for population.
Yeah, so it's a good point, and one of the things I've done in the needs assessment is looked at the proportion of the population that's accessing care. So that's based on the latest census data, so that we can actually see, rather than absolute numbers, we can see what that translates into the proportion of the population are accessing care. So we can look at the areas where we've got low proportions of the population accessing care.
And when were those last census figures done? Because we've had a huge increase in numbers of people, I can only speak for my particular town, due to the housing crisis nationally. So are you using figures in terms of registration with GP practices? Because most people, when they move to an area, the first thing they do is register with a GP practice. How up to date are census figures? Because then that's going to skew your idea of how many people live in an area. And on that note, are we planning in terms of emergency dental care for the potential increase of number of people that will be needing to access that via Scampton? If we're looking at population as being the basis for UDA allocation, and we're aware that population has increased significantly. Just want to make sure that that UDA allocation is actually reflected, you know, that population is reflected in the allocation.
So if I answer the population question first, I've used the census data, and one of the things I've said in the needs assessment is that whatever data I use, it is a snapshot in time, because things change on a daily basis, and it's impossible to keep a needs assessment up to date with that regularity. So whenever the needs assessment is used for developing a commissioning strategy, it needs to be used with local intelligence as well, so that if something significant has changed, like there's a big housing development just come online, or things like Scampton or whatever, then the local intelligence that the commissioners have to be used with the needs assessment to develop the commissioning strategy.
Okay, I've got Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. Well, I'm glad Caroline mentioned communication, because I can only speak from my experience. I learnt from local gossip that my dental practice had closed down. I've never heard from anybody. I've never heard from anybody in Lincolnshire suggesting where I might access dental care, blah, blah, blah. I could go on forever. What's happened to my dental records? Who knows? Who knows where they are? And the whole, I think it's lovely you have strategies, but we are people who work with people from the ground upwards, and you work downwards, I know. And the two don't actually hit the right bit half the time. But I know in Louth we struggle with dentists, absolutely struggle. And the people who went to the practice that shut down that I went to had been around all the dentists. They could only then go to a private dentist. It was costing them thousands to have a tooth done, blah, blah, blah. We really were landed in it with so little information. And communications is the only way systems work properly. And you keep saying it's bad on the East Coast. It is jolly bad. I don't think you have any conception of how bad it is. And I know from people I've spoken to in Mablethorpe, I was told that was full up already. No, that's not the case. Right. Well, that's healthy. But I don't suppose the people that went to the practice I went to are going to go down there, because nobody knows anything about them. It's really difficult, because some of my family now go to Grimsby for their dental health, but we don't know. We haven't a clue what's going on in Grimsby, but we only live 16 miles away. But the strategy doesn't take in the whole area that we have to access either. So I feel really frustrated, but I'm glad you're having all the strategies, and eventually something might happen. But I desperately need to see a dentist, and I don't know where to go to.
There is change. There is change within the national contract. The dentists they have to be very clear about who's taking NHS dentists on their website. I will take back your point about communications. There is a responsibility on the dentist leaving to actually communicate that well with patients. But I will take your points on board, and we will feed that back to the team. Would have been working with the practice that shut, or what they would have done is they would have shut their element of NHS dental care, not their private care element. I'll take on board your points, Councillor, and I will take that back.
But what happens to our dental records?
They remain with the provider, so they're never passed on. They're the provider, so it's their responsibility what they do with them afterwards. So they'll have to store them for 25 years, and then after that they can dispose of them securely.
Well, without going on for too long, but how on earth do we then get hold of our dental records?
You don't need to, and you can't. Nobody ever transfers their dental records from one provider to another.
Oh, so it's not like doctors?
It's not like doctors, no.
Right, thank you.
So I was just going to come back in as well, if that's okay, Chow, about the original query from Liz, Health Watch, and it actually fits in with what's just been said as well. There's been a change in the way practices declare their available appointments on the website, on the NHS website, because that was previously always thought to be confusing. Previously, it was cut or dried. You were either accepting patients or you weren't. The practices, as soon as they accepted patients were then inundated when they couldn't cope with them. So they tended to not say that they were accepting patients. So if you looked at the website, you couldn't actually find one that was. Whereas now, it's only a subtle change, but it's supposed to make it easier for providers. They now say, if they choose, they're accepting patients when they have capacity. So hopefully that means that people, just that subtle change will take the pressure off them and allow them to put that. And it has made a difference. I checked the week after it was done, and there are now a lot more who previously said they weren't taking, and now, so that would be a place to look. I can't guarantee that it'll work, though, because it depends on capacity, obviously.
Okay, thank you. I haven't got any more speakers, so I've got a few questions myself. I'll bring you back in a moment, Councillor McGee. I think Liz has alluded to quite a bit of what I was going to say, but access to NHS dental service is probably one of the areas most raised with me as a councillor, especially in Skegness, where residents are contacting the local NHS dentists and being advised simply they are not taking on new patients, often without any further advice on how to get an appointment or where to go to access. They're often then been trying to turn to private dentists to now where we're having in Skegness, they're saying, actually all the private dentists are full, and so you can't see a private dentist either. So I refer to section 7.5 of the report where it advises what actions the ICB are taking. Can you actually inform the public of how to access an NHS dentist and where and how these vans will be accessible? Because at the moment, it's, as has been alluded to, it's fantastic. We've got, you know, these documents coming forward, but man on the street or woman on the street, you know, it's not helping. It's not at this point. Thank you.
I think we have to be very careful with advertising a dental van service to anyone. I know it's the whole concept of it is to make it very available to everyone, but they have minimum capacity. They'll probably be able to see 12 patients a day, let's say. And you can imagine if you advertise it, then they would be inundated and it would be queues. So it's a question of trying to manage it somehow.
However, we will take through the dental network group to see how we can improve communication and at least be clearer for patients on where and how they can access urgent care and primary care.
Yeah, I think communication is one of the weakest areas that we're seeing all across at the moment in time, so thank you. My next question is, at Appendix 1 on page 42, the report mentions 80 dental care trainees across the East Midlands. Can you advise what the ICB is doing to try and entice some of these to practice in Lincolnshire, and how a regional relationship will not simply leave us as the poor relation?
Can you repeat what part of the report, please, Chair?
Yep, certainly. It is Appendix 1 on page 42, and it's in regards to the 80 dental care trainees across the East Midlands.
Then when's the core training?
So this is core training, which is in secondary care. As far as I'm aware, they've been inundated with applications over the last 2 years, so all places available have been recruited to. Some have been recruited to by international dental graduates. So I alluded to earlier that working here as DCPs, they can actually work in this role. So they've actually moved into this role, working in the area. So we're doing what we can.
And as previously, Lincolnshire is really one of the key systems to work with for the Workforce Directorate. Everything is being prioritised to support communications, education, to support getting trainees into this system.
And we have a significant number of dentists in Lincolnshire who are not working as dentists, who are working as DCPs, dental care professionals, dental nurses. Some are working as hygienists, some are working as therapists because they're waiting to sit their overseas registration exams to therefore hopefully come on our performers list. We have a significant number in Lincolnshire like that. And they have chosen to come to Lincolnshire, I may add.
That's promising and good to hear, in fairness, thank you. My final question is, how well are the delegated commissioning arrangements working, and how has the ICB's role in assuming responsibility for commissioning dental services since April 23 worked in actual practice?
Thank you, Chair. So as you say, I think that we would say that it's working really well. We've just celebrated the 12 months, I suppose. It's been 12 months since we've been taking over the delegation function. But as we've talked about today, we've moved such a lot forward now. With the dental strategy development was pre-delegation. We've been able to implement and move a lot of things forward, both on what will be Lincolnshire ICB priorities, but also working collaboratively with the East Midlands. So we have seen lots of good shared working, some shared developments across the East Midlands that has benefited both on a Lincolnshire and a wider footprint. So this is our first year, so we're evolving and developing it further. And we've just touched on some areas continue to be prioritised, even through that collaboration agreement. The example is the dental van that we've touched on, which has very much come out of the work that we've been doing on our understanding our needs of the population, our access. We've been able to still continue to signal that Lincolnshire is a priority for focus. The improvement on the UDA rate, again, was acknowledged that Lincolnshire had some way to go, hence further work that we are still looking at what further enhancements we'd want to do, both on a Lincolnshire and through that extended collaboration work. And lastly, just talking about the importance of the workforce training and development. So part of the approach we've taken is shoring up the short term. There's no quick fixes. We were made that clear a year ago. But what we did want with the strategy is making sure that we're putting the foundations in place. And what you've heard so far is the work. We're focusing on ensuring we've got our workforce in place at the same time trying to meet the access. So the work in the last 12 months and certainly in the last few months on Centre for Dental Development that we've touched on certainly is one of our big cornerstones. So I think through delegation we've been able to develop that at a much faster pace now. So look forward to being able to provide further updates in the next 6 to 12 months on what that continued journey looks like. Kenny?
I'm a clinical dentist working in practice and also at the hospital. As well as chairing the local dental committee, I also chair the local dental network. What I would say is the support I feel I'm getting as a chair from the ICB, from NHS England, is significant. We are doing things in Lincolnshire. We've alluded to the Centre of Dental Development, and there are other things going on in Lincolnshire as well that I feel really supported by the group around me. And I don't give praise, by the way. I really feel that. I go to meetings, and what we're doing in Lincolnshire, other areas are certainly not doing. Thank you.
Thank you for that. Councillor Linderwood.
Thank you, Chairman. Firstly, I'd like to thank you for the paper. You've given us so much information in this paper. It was really good to read it, and for your presentations this morning. But Kenny, you mentioned something. I'm always quite passionate about children, and I think they're little sponges, and they take things on board, and they target their parents with these good things. So could you tell me a little bit about Smiles? Do you just go into sort of preschool, very junior schools? I mean, back in the dark ages when I went to school, we had a school dentist. But if you could just enlighten me, that would be really nice. Thank you.
So I touched on prevention being far better than reparative. One of the things in schools that we see because of lack of access, and not just in Lincolnshire but throughout, is children are taking time off school because of issues with their teeth. Admission to hospital for general anaesthetics, it's a figure that we've often said the most common reason for admission for general anaesthetics for under 12s is dental extractions, which is horrendous really, because dental decay is totally and utterly preventable. So we're dealing with a totally preventable disease. So if we can access our schools using it's the community dental service and their teams who are going out, and as that we're ahead of the game in this, and we have been ahead of the game for a while really, but it's targeted, you know, because we know where the areas of deprivation are. In deprivation, dental decay is linked very much to deprivation, so we can, and Anna will possibly come in as well, because Anna's obviously done work in this really. So you know, going to schools is a very key part of our strategy, really. And also education. You know, education is equally as important, really. Fluoridation is not a magic bullet. You know, it's part of prevention, but you need education so that the children are not drinking 2 litres of bottles of Coke every night with their evening meal. It's things like that, really. Yeah. Thank you.
Thank you. Councillor McGee for the final word.
Yeah, hi. I just wondered if there was any figures with regards to when people contact 111 looking for an emergency dentist, how many people are actually successful or have to phone back because they've been unable to see an emergency dentist. Because obviously, you know, I looked on the link to find a dentist for my town. There was none at all, and they were having to travel across to another county to be able to find an NHS dentist. So at that, you know, you're going to get to a point where people need to access emergency dentists. So I just wondered how many people are successful when they contact 111 to allocate one. And I was just looking at some of the triage figures, and you know, severe dental or facial pain, just advise patients to call back if their condition deteriorates. And I wondered, you know, if I had severe pain, extreme pain that couldn't be controlled with self-care, just waiting to see how bad that got wouldn't really satisfy me if I was phoning 111. So I'm just wondering, you know, do you have some figures at how many people actually manage to access emergency dental care very quickly after phoning 111? What are the timescales?
I don't have the data today, but I will find it and we'll source it and we'll send it through, and we'll take the next update for dental chair if you agree on the more urgent. That we'll take that lens in our next update. Talking about the clinical pathway, do one of you want to talk about that? For urgent care, about the waiting and the self-care.
The urgent care is actually defined in dentistry, and it's quite narrow urgent care. What we're now seeing and having to manage is semi-urgent. So you may see urgent patients, but there's actually people who are more urgent that they don't know about. So we're having to manage, and that's why the triage system is there in place. I actually work in urgent care, not in Lincolnshire but elsewhere, and I can tell you that there are patients who come through the system with the toothache. There are patients who come in with raging abscesses that need to be prioritised first, or bleeding from their mouth that is urgent, and we're avoiding them having to go to A&E by managing them. But we can't see everybody, and as we've already discussed, the access to dentistry is reduced, so it makes it very difficult, and somehow you have to, if you phone back, I mean, that's to sort of try and say to them, because everyone's idea of pain is different to everybody, isn't it? So everyone's level of pain, so the system is there to try and work out who is more urgent at the time. And you may be offered an appointment with the urgent care immediately, or you may be offered it at a later date, for example, a day later, something like that. So it's not ideal, but it's the best that we've got at the moment.
I think, if it's okay, Chair, just to say that those figures would be really helpful for us to understand whether or not urgent care is actually meeting demand, and it goes back to commissioning. So if we had appropriate UDA allocation for dentists in Lincolnshire, then we would have greater treatment being available for NHS patients. And I know it comes down to money, and I know the work is being done, which is really positive, to look at where the needs are, but sooner rather than later, because the reason urgent care is in such high demand is because that NHS dentistry, and as Councillor Smith said, there's a reason we all go to the dentist once, or at least once a year, and get our teeth checked. It's to prevent this from happening in the first place. So there's lots of positive things that I'm hearing today, but I really hope that you guys are going to look at the level of UDA allocation in our practice, in our NHS practices, across the board, because you're talking quite a lot about the East Coast, and I get that that's where there's really high need. but we're in Gainsborough. I just clicked on the site to have a look, and people have got to travel out towards Epworth and that direction to even hope to find a dentist that's going to provide them any care. And in a rural area with high levels of deprivation, like somewhere like Gainsborough, and very poor bus services, that effectively means that somebody does not have an NHS dentist, and that's why they're then going to be accessing your urgent care. Okay, thank you very much.
Anna, I think you've indicated you want to speak as well.
I was going to come back on the prevention question, but if the moment's passed, I'm happy to step aside.
No, I think if you've got something to say, you might as well add. I think it adds to
Okay.
the debate.
So it's just on the point of the work that we're doing in schools. So part of the Lincolnshire dental strategy is a prevention strategy. And what we're doing as part of that is actually targeting areas and children and schools and preschools and things around things like actually giving them a toothbrush and toothpaste, because we're hearing that that's a real barrier at the moment for some families. And we know that by providing toothbrushes and toothpaste, we improve oral health. And we're also going into schools and early years settings where we're developing a program of actually brushing the children's teeth in schools so that that becomes a habit. They get fluoride toothpaste and they understand how to do it. So it's that sort of things that we're doing on top of the wider population stuff like water fluoridation and things. So it was just to reassure the councillor that there are some very specific programs for young children as part of the prevention strategy.
Okay, thank you. That's useful. I'm now going to move to a proposal. So I propose to welcome the opening of an NHS dental practice in Mablethorpe and the improvements being made to date, to record the committee's concerns that 4 NHS dental contracts have been handed back since the last update to the committee in July 2023, and to thank our presenters for their report and attendance today, and to update us further in 6 months with the data as requested, please. I have a seconder for my proposal. Thank you, Councillor Hayes. All those in favour, please show. Thank you. That's supported. Thank you very much. Okay, we'll now move across onto agenda item 6, urgent and emergency care and winter 23-24. This item was circulated as part of the agenda pack on pages 43 to 79. This item enables the committee to consider an overview of urgent and emergency care activity, including the standard where patients should be seen or discharged within 4 hours. There has been a plan to consider the review of urgent treatment centres at this meeting, but this is not yet ready and will be considered on the 12th of June 2024. I'd like to welcome our presenters in person: Claire Raybould, Director for System Delivery, NHS Lincolnshire's Integrated Care Board, and Julie Frakes Harris, Chief Operating Officer for United Lincolnshire's Hospitals NHS Trust. Welcome to the meeting. I'll give you a second just to sit, and then I'll hand over to you if you can lead us through a presentation for about 10 minutes and questions at the end. Thank you.
Yeah, thank you, Chair, and hello everybody. Nice to see you again. So as you've heard, I'm Claire Raybould. I'm the Director for System Delivery. You've got the paper in your pack. I'm not going to go through it in detail. I take it that you've read that. But what the paper's designed to set out is where we are in Lincolnshire in terms of the National Urgent and Emergency Care Recovery Plan. You'll recall when I came back in October, I think it was, there was a 2-year recovery plan published, so we're now just into the early part of year 2. And we also described last time the winter preparedness that we were doing, and you've got a copy of the winter plan that was published after I last came, also in your pack. So we're just going to talk a little bit about how winter landed for us in Lincolnshire as well today. Appreciate that we're now officially out of winter. We come out of winter after the Easter break, so we now are officially out of that. Although the weather this week, you never know, do you? So as we anticipated, it was a really busy winter for us, and you can see that in the data, and it was quite challenging, but we did have quite a typical respiratory virus presentation, which again you can see in the data. So we expected that to be a bit worse than it was, to be honest, and we don't really know the reasons for that at the moment. That's still being looked into, but obviously we knew the winter before, as we discussed last October, was quite different, wasn't it, with the different viruses that we hadn't experienced, as well as COVID at that time. So it was better from that point of view, but it was challenging. We said last time that the biggest risk to winter was the continued industrial action, and unfortunately that did continue, and we actually had dual industrial action of consultants and junior doctors at the same time for very long periods. And as I explained before, the work we have to do to prepare for that, to deal with the period of industrial action and recover from it, is really significant and often unseen. So very challenging. We manage it really well in Lincolnshire. Sadly, we've become quite good at managing that as best we can, but it does have an impact, and it certainly impacts patients, and we know about that. We also know, and I've stated that in the report, that we haven't always been able to offer the timely access that we would want to, and that patients do often wait longer than they need to. But what we've also been able to demonstrate is the improvements that we've made as part of our recovery plan. And you can see in the paper that we have actually improved, and we've delivered some sustainable improvements, which I'll talk a little bit more about. The recovery plan was primarily focused on the A&E 4-hour performance and also ambulance response times. So you'll know the national standard is 95%. It's a standard for a reason. Julie, who's with me, and myself, we feel really passionately about why that standard is there. It is to make sure people get good care and timely access, and that's what we're working towards in terms of this year's plan. That said, the national target was set at 76%. It's been set at 78% for this financial year that we've just started. We landed the year, you've got February's data in there, so we were just shy of 72%, and largely that was as an impact of the industrial action that we experienced. It was quite difficult to recover that. And nationally, that's in line with where regionally, that's in line with where everybody else landed, but nationally it was about 74%. So in a less rural area than Lincolnshire, it's a bit easier to deliver that target than it is for us, and we know about that. We've also had the changes in terms of number reporting from Grantham when it changed last November from an A&E department to a UTC in terms of where the data is reported. It now shows in urgent treatment centre data rather than A&E data, but does all support the position. So what you've got in your pack is the description of some of the things that we've been doing to improve. So the group, which I know we're going to talk about in the next item that Julie's here towards. So the group being ULHT, the Hospital Trust and LCHS, have done some really fantastic work together to integrate some service pathways, which really is improving outcomes for patients in our ED departments, but also preventing them from having to go there in the first place. We talked last year about the healthcare professional SPA. So this is health professionals being able to ring into a single point of access where they're not sure what they can do with a patient, and hand the patient off, and then the patient can be dealt with in the most appropriate way, instead of trying pathway one and it doesn't work, trying a different approach and that doesn't work. And the ambulance trust and our ambulance colleagues have said that's made a huge difference to them and their turnaround times, because they're able to deal with patients on scene much quicker. And again, you can see that in the data. What you can see is in the bit about ambulance handovers in particular, and the category 2 mean target. So that's the response time that we expect for patients in the community. In the winter previous, we saw a big spike in delays of people waiting for care in the community. And we know, don't we, from when I came last time, some really difficult stories about patients that waited for ambulances in the community. We didn't experience that in the winter this year, and it's been much better. And we are continuing to sustain that even through all of the winter, despite the fact that, as you can also see in the graph, the demand was significantly higher. We've also improved the time to first assessment in our ED departments, and again you can see the numbers of that. While still not acceptable to have people waiting, it is much, much lower, and you can see the improvement in that. And that means people will get a decision quicker about what their next step is. the next bit of the work that we're doing this year is to work on our discharge and flow pathways, both in the hospital and out of the hospital, so that once we've made a decision to admit somebody, we can move them onward in their journey quicker. So all of that is showing sustainable improvements. And 4-hour handover delays is something we don't need to talk about anymore in Lincolnshire. That was a significant issue for us. It's 92% less now than it was winter last year, which is absolutely fantastic. And in fact, we rarely talk about handover delays of more than an hour now. They're a rare occurrence, and because of some work that Julie and I and our teams have done, we have a really strong escalation process. If we're in that position, we understand why and we work to improve it as best we can. So that's great for patients, because that means ambulances can hand over quickly. They're not stuck outside hospitals for long lengths of time. And we've also been doing work with NWAFT and NLAG in that respect as well, so not just for ULHT. We have put the average handover times in the document for February. I have seen some unvalidated data for March, which shows a better position than that, and a much better position for NLAG actually as well. We continue to focus on caring for people in the community where we can. That's absolutely the right thing to do, so that our urgent and emergency spaces can be for those patients that really need those. So we're still continuing in all the messages of calling 111 first, so that we can book people into appointments. We know that we had some issues when we first did the UTC at Grantham in terms of being able to make that available, but that is now working and in place, which is really positive news. And then just in terms of some of the things we did this winter, so we did acute respiratory hubs over the winter, so that was on the back of learning from the previous winter. So this is where patients were able to go and see, primarily led by GP services across the county. We didn't get every part of the county covered in that, because we were reliant on the capacity of people to come forward to deliver. But we were able to offer those services. We've just done a bit of an evaluation, and it's still ongoing at the moment, about what we're going to do this winter. And I think what we'd like to do this winter is build that into our urgent treatment centre model, because people understand where they are and how to access those. And I don't think we need to make it any more complicated than it often is for our patients. So we're still in the design stages of that at the moment. I've referred to NHS 111 in the paper just for your information. So there's a new contract that's been procured for NHS 111 across the region. Many regions operate like that, but our region had 3 different providers actually, which does make it less resilient when there's an issue with 111 calling. So in terms of the local service, though, the clinical assessment service that we have in Lincolnshire, that still remains. So we still have our local clinical assessment that 111 will hand over to. So it's the same provider that we had previously. So from a transition point of view for Lincolnshire residents, we're less concerned about a mobilisation of a new provider than we might have been if it had been one that we weren't familiar with. So I think that's probably where I'll leave it, but happy to take any questions. I think I'd just summarise by saying it was a challenging winter. Industrial action did cause us more problems than we anticipated, I think, but we managed that really well. We're in year 2 of the recovery plan. We've got a good plan in place for this year, and our ambition is to recover greater than the national plan, because that's the right thing to do for Lincolnshire residents. Thank you.
Okay, questions? Right, I'll start the ball rolling then. Can you explain, with so much of the winter plan's targets being set in 2023, why this document is in draft? Does this document have associated KPIs, and if so, can they be shared? And finally, can you expand now on what has been achieved up to date?
Yeah, sorry, I don't know why it has a draft watermark on. I don't know whether we've just sent you an incorrect version, Chair, but the published one certainly doesn't have a draft watermark on it. So when we set the winter plan, the Urgent and Emergency Care Partnership Board meets every month and has an underpinning winter delivery group, and they do monitor the KPIs. So what they've been monitoring on a daily basis over winter is where are we against the 76% performance in A&E, for example, or our Category 2 response times or our ambulance handover time. So every one of those metrics is monitored through that delivery group and reports up into the Urgent and Emergency Care Partnership Board. And that partnership board is attended by everybody across Lincolnshire, but also North West Anglia Foundation Trust and North Lincolnshire and Gould. So we cover providers that obviously are outside of the county, but actually where our residents obviously do access that care. So yes, we can share more information with you. We have statistics coming out of our ears around urgent and emergency care, and a lot of it is published available. So be very happy to share more information if you just want to let me know what you'd like to see. I know if you want to do a deeper dive on that, we can do that next time we come, no problem.
Okay, thank you. My next question is on page 73. The first paragraph refers to moving the workforce around where needed if critical service are understaffed. As LCHS and ULHT are working as a group, will we be seeing more overnight closures of our UTCs to move staff to A&E departments? And if so, surely there is the potential of more pressure on A&Es with more patients presenting with minor ailments.
I'll make a start and then Julie might want to come in. So you'll remember last winter, because we talked about it when we came, we did have to close some of the urgent treatment centres overnight, not particularly for winter pressures actually, it was about industrial action. We've not had to do that this year because of the way the group has been working. So it's about moving the right skilled staff to the right location to make sure we can maintain all services. And as you know, we're doing the urgent treatment centre review, and that's certainly part of the direction that we want to go in. We need to be able to maintain them, but how do we make that access appropriate for them? And how do we make sure that the staff are in the right place for the right presenting patients? Because not all of them are seeing the same level of demand and at different times of the day and night. So it's a really positive move, what we're doing, rather than seeing it as a negative. And certainly we haven't been in a position for over a year, I think, where we've had to close one of them, which was a frequent occurrence, as you'll recall. But I'll let Julie come in, as it's her teams.
Thank you, Claire. Thank you, Chair. I don't see this as a negative issue at all. In fact, from a workforce retention and enticement point of view, our people find this really positive, that they are able to work across the whole pathway and gain different experience. So actually the ability to gain that experience has been seen and received very positively across what we call the group model across both the acute and community services. And as Claire says, we haven't been in the position of needing to shut any of the UTCs, which is also positive as well, particularly for our GP, our medical and for our advanced practitioner workforce, which, as Claire says, with the industrial action has been under considerable pressure at points. We've been able to flex to make sure we've been able to meet our community's need in a much more responsive way than we were able to previously.
Thank you. I know you have stated that you have managed to achieve your target of 76% overall. However, could you please break down on an individual UTC or an A&E basis, what was the actual percentages for each individual one? And if any performing significantly worse, what actions are being taken or have been taken to improve those?
Yes, just to clarify, we didn't hit the 76% at the end of March. We were just shy of 72%. Nationally, it was 74%, and our region was 72% also. So there is variation. There always will be because of the type of presentation. But what we call them is what we call type 1 and type 3 departments. So an urgent treatment centre is type 3 and the A&Es are type 1. So we do have that data broken down. And what we do have is a real challenge with some of our type 1, and that's not just at ULHT, that's at other providers as well. But you would expect to see that your type 3 urgent treatment centres operate at around 90% or above. That's what you would expect to see from a 4-hour target, because generally you're seeing much less serious issues in those. Having said that, though, obviously it depends on how people present and if they then need to go onward into another service. Where you look at the type 1 department, so nationally in England it's about 60% for type 1, and for us in Lincolnshire I think we were about 50% on average. I don't have the stat on the top of my head, but we know that's where the work is that we need to do to improve in our type 1 departments, which is why we're doing the work that we're doing in the recovery plan. And actually that's come from a much lower base than that at the start of last year. But I'm happy to dig that data out and share it with you. That's no problem. Julie, don't know if you want to add.
Yeah, Chair, also the opportunity through the national requirement and the big spotlight that we know that we were asked to put on this particular target for the right reasons did give us the opportunity very quickly at the beginning of that review to see the incremental differences we could make around practice, particularly in that type 3 provision in the UTCs. So we were actually very quickly able to make supportive changes that actually, when we share that data, you can see also over the first couple of weeks of spotlight monitoring, we were actually able to increase our delivery to some days to 96-97%, and that's using the see, treat and discharge model across urgent treatment centres, which I think is really, really positive, because hopefully our citizens were experiencing something that means for those non-true type 1 presentations, they will continue to use our urgent treatment centres closer to home, but also therefore keeps a decompressing focus on our ED departments. So actually the national ask was a positive for us in Lincolnshire.
Okay, thank you. And with ULHT still being one of the worst performing A&Es in the country, what can residents actually see in terms of improvements?
Shall I take that? So actually what they can see, and they have been experiencing, is a very big improvement. Our CAT2, so the time to wait for an ambulance and the time on the tarmac at either Lincoln or Pilgrim has been, I really mean hugely reduced. We are now escalating and focusing on any crew that might wait occasionally for up to 30 minutes. That's become our new normal. You know, when I had the privilege of joining Claire as the COO for LCHS last autumn, that wasn't the case. We were experiencing 4-hour waits. So our patients are experiencing much more timely support and treatment. Also, our time to first assessment, we've been able to re-look at the whole medical model. We've consulted with our doctors. We've been able to put in a new rota that we can also see that time to first assessment, and therefore the ability to support our most acutely unwell patients to have a decision as to what path they will now be treated upon, has absolutely reduced. Sometimes they were waiting for up to 10 or 12 hours for that first interaction. After triage, we now keep that well within the limits of an hour to 2, which is absolutely in line with the national delivery. So I think that we're hearing as well from our patients, because we're regularly asking our patients about their experience, that they are experiencing something that is much more responsive than they were even a couple of months ago, Chair. And you can see that in the data.
Okay, thank you. I still have no further speakers. I understand that the mental health assessment unit in Lincoln, referred to on page 71, is one of only 4 in England with an item on its benefits to patients featuring on ITV National News last week. How has this benefited the system overall in Lincolnshire?
Thank you, Chair. Yeah, really, really good question. Really pleased to see that little glimpse on ITV News of the Mental Health Urgent Treatment Centre. That's made a huge difference. For individual patients, if you've got a mental health crisis and you're in an ED department, it's not the right environment for you. And often your length of stay in that environment will be very long. And we see that when we're on regional calls with other colleagues that don't have what we have, and we have a lot of those people come and visit us to see what we're doing. So it makes a huge difference to patients. It gets them the right treatment earlier than they would do in an environment that's more suitable. And from a performance perspective, that also means that, you know, if you do have challenging a mental health presentation in ED, it can take a lot of resource as well, and they're not necessarily the right trained resource. So obviously that impacts on other patients in the department and is distressing for other patients in the department. So from a performance perspective, we've seen an increase in our performance. And this winter, it was a big focus of how long people were waiting in ED departments with mental health presentations, and we just weren't featuring in that at all because it wasn't an issue. Clearly, the next step for us now is to get more of those in the county, because obviously we've only got the one at Lincoln at the moment, but we're looking to see if we can do a similar model out at Pilgrim, and then look at what else we need across the county as well. So it's a hugely positive benefit for Lincolnshire, and we're continuing to. We've seen that, we've evaluated it, we've had it properly evaluated, and we can demonstrate that, which obviously then gives you the blueprint for being able to do further sites.
Thank you. I've now got some speakers, so I've got Councillor Mackinson-Saunders first, please.
Thank you. I do still hear a few complaints about A&E at Grimsby, especially people sitting in A&E and drinking out of beer bottles and things like that, which is really sad. And I find there's lots of older people that find that really disturbing. But I think there's a lot of deprivation there, so I understand why all that happens. But I just really wanted to give a big shout out for the Urgent Treatment Centre in Louth. It's brilliant. That everybody raves about how good they are. So thank you for that service. Don't cut it, whatever you do, or else I'll be waving a flag. But it's a really good service for the town and the area. So thank you very much indeed for that one.
No, thank you. So we'll take that back to the teams. They'll really appreciate that, and they do deliver a really great service out at Louth. So it's excellent. I'll also take your comments back about Grimsby when we next speak to our colleagues up in the north. So.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. I note what you've said about the data, but as I said in a previous item, and you were probably on the way here in the traffic, there are still a number of instances where people are waiting to be seen, and even in this instance they were waiting for a bed in excess of 10 hours. Granted, that is a weekend, and I appreciate they are always busy, but when you are in searing pain in an A&E department and not even on a bed for about 8 to 7 hours, that's a heck of a long wait. And now, whether whether other stories are more anecdotal rather than factual, I don't know. I know that one is fact because I was getting updates as it was happening. When are we going to see a time where, and I know we're moving in that direction, when are we going to see a time where they are really, horror stories that are once in a blue moon, that, if something untoward's happened? I mean, I know a number of months ago, for example, we had that awful fire situation at the county hospital in the imaging department. It's something like that would trigger that, rather than, they're busy and they've waited 8 hours on it. But I know you've come a long way from last year, so I'd like to pay tribute to you for that as well, because I know it's been hard work, especially in the environment you've been working in. But I think there's still some occasional horror stories that come out, unfortunately.
You're absolutely right, and thank you, Councillor. I think you're absolutely spot on. It's our focus to make sure that nobody experiences a long wait in ED, and we've had a two-pronged approach, and the group model has definitely supported us with that, and it does still happen, and it's not something that we are the slightest bit proud of. In fact, it's our absolute focus area. So one, we've put in a completely different approach to what we call care and comfort across all our EDs and UTCs. And that's been really led through a very clinical nursing lens, which we've had patient experience feedback. So when those patients do need to wait for a considerable amount of time, particularly for a specialist bed, to make sure that we get our patients into the right place of speciality, that they are treated and that their treatment has started. So it's not a feeling of holding. It is a feeling of treatment. Also, because of the success of the work across the pathway in UEC that Claire has been sharing, we've taken that approach to discharge, because we all know that actually the flow through our ED services is at its speediest when we're able to support our patients when they're ready to get home to their bed, because it's by having those beds ready that we are able to move you out of ED. So that is our absolute focus area over the coming months. We've started that. It's got good traction already. And the patient stories at the centre of that work, please be assured. So you're absolutely right. Thank you for helping me validate the fact that our next big piece of work is in the right place.
Thank you. I've got Councillor Martin next, please.
Thank you, Chairman. active recovery beds. I notice here it says it's increased from 30 to 70 over winter period. First question is that now a permanent thing as we move forward? Obviously, from what I can see here, active recovery bed basically means a patient will move to a care home whilst they're awaiting, I presume, adult social care to get a package in place to care for a patient. Who actually monitors that care home provision? So when a patient is put into a care home, who actually makes sure that it's the right care and they're looked after? And is that down to a GP, or is that something that you would keep an eye on? How long are patients normally in this active recovery for? And obviously the main point is, are the patients happy? Where do you get the feedback from them and the satisfaction levels?
Yes, thank you, Councillor. So active recovery beds, as you can see in the winter plan, we have them all year round, but we always put more in. We put more of everything in over winter. So the numbers that you see in there was what we put in for winter this year, and we've stepped back now post-Easter, so we kept the number up until after the Easter break. And we now step back to our normal operating numbers over the year. So it's a combined piece of work with the NHS and the local authority, active recovery beds. So they're commissioned through the local authority, so they monitor the care home aspect of provision, if you like, and they also monitor the social care support into them. And then from a health perspective, we do this collaboratively, so it's not in isolation. We monitor so they all have an aligned GP practice that monitors the patients that are in those, and then they have wraparound support from community services and others as required. So the purpose of them is to... There are many times when people can go home, but they need a bit of active recovery before they can go home. They're not unwell enough, they need to be in a hospital anymore, but they're not well enough to go to their own home at that point. So they go into the active recovery bed and get that wraparound support from community services, therapy, social care, the GP, to get them back to what is their new normal, because often for those people it won't be what it was prior to them going into hospital. So it's to get them back to a level of recovery that they then can go on to their onward pathway. So some of those people then will go home, and then they might not need any more care. Some of them might then need a package of care. Some of them, things may change and they may need something different, or they may choose they want to go into supported accommodation. So again, we'd be happy to bring back a report on that. We do have a very detailed report that we receive every month that tells us what's happened, the length of stay for those patients, and it is really, really positive. And the feedback that we get from residents that go into those and from families is really positive, because they actually are able to see their family member or them as an individual get back home, which is what the premise of them is. Home first, that's where we want you to go after being in those, but we know not everyone can meet that, so that's the purpose of them. Did that answer all of your questions? Yeah, thank you.
Okay, thank you. I've got Councillor Button.
Thank you, Chairman. Good morning, Claire. Could you tell me where you found 91 additional community beds during the winter period? Were any of them within the Grantham Hospital at all? And then I want to speak about something else. Shall I say it now? Or?
Can do, yeah.
Yeah. Well, yesterday afternoon, I spent probably upwards of 4 hours at the UTC in Grantham, and I was supporting a vulnerable person who's in one of your virtual wards. And previously I'd met one of the virtual nurses. But what I want to say is I was really pleased with the way the people came together to ask the right questions, to realise that the patient that I'd taken in had problems, because I was sitting there thinking, how on earth am I going to get this patient home? She is a friend, and I do support her, because I had an awful job getting her out of the house and to the hospital, and I don't know what the problem was with getting her an ambulance. But anyway, I was really impressed because she had to have a splint. The doctor was lovely, young lady doctor, and they were concerned that there were other problems going on. And then another nurse came in, and I assumed she was like a coordinator. And it was decided that she would have to stay in at least overnight. So that was really pleasing for me, because I was thinking about all these problems, you know, getting her back home, getting her into bed, etc., etc. So I just wanted to put that on record that, you know, the performance was really good at our Grantham UTC. I know it's a different story from days of old of being in A&E, etc. But praise where praise is due. Thank you, Claire.
Thank you, Councillor Wootton. That's really lovely to hear. Sorry to hear about your friend having to take her in, but it's really lovely to hear that she did have a good experience once she got in. And I think that's part of the model at Grantham, isn't it? That it's a holistic model, and we're able to access the support of not just what you would see in a traditional urgent treatment centre, but community support, and make sure the right referrals are done for patients that attend that need something more than just what the urgent treatment centre can offer. So it sounds like they were able to do that. So thank you for sharing that story, and we'll take that back. In terms of the community beds, so most of those community beds are in care homes as opposed to what we would traditionally call community hospitals. We did have some in community hospitals, so we had Welland Ward out at Spalding, and we did increase some of the beds in some of the areas. So there wasn't any specifically at Grantham this time round, was there? But obviously there's the work that we're ongoing that we're doing at Grantham in terms of the bed base there, and what we're doing in the future, and the frailty service that we've got operating at the moment. So the majority of them were in care homes, so part of the additional transitional care, active recovery and community hospital beds.
Thank you. Thank you, Chairman.
Thank you. I've got Councillor Matthews over Teams, please.
Interesting discussion. I want to raise an issue that we cropped up previously. I have a resident who has an ongoing heart condition, 80-year-old gentleman, suffered chest pains and dizziness at home on a Monday evening, 7 o'clock. These signs the same as a previous heart attack scenarios that both he and his wife recognised. Ambulance came, and the patient requested that they would like to go to Lincoln, where they'd been seen on a very serious, there's an ongoing issue, been seen on a very serious issue. The ambulance said it was not possible. He was taken to Grimsby. On Grimsby, the patient was seen on discharge from hospital and placed into triage. After 3 hours in triage, he had a massive heart attack. He's currently in Castle Hospital in Hull, which is a 2-hour drive away. He suffered oxygen starvation, deprivation during the heart attack. He was probably without oxygen for 15 minutes, as suggested by the hospital. The wife is asking me why on earth were they to Lincoln, where there was a history and they were understood. Why were they taken to Grimsby and then taken further on? As part of his recovery, they've asked to come back to Lincoln, because this lady can't drive, so it's extremely difficult for her to get to Castle Hill. And they've been told Lincoln won't take him back because they don't think they can do anything with him. It all seems very curious. Thank you, Chair.
Yeah, thank you, Councillor. I'm very sorry to hear about that story. That really doesn't sound very, very nice. Obviously, I can't answer why that happened, but if you want to share some details, we'll happily pick that up with the Ambulance Trust and see if we can find out. You know, usually it's around clinical presentation and where is the nearest hospital, and what the kind of the service that the person might have needed, but I genuinely don't know the answer. So, but I'm happy to support looking into it for you if that would be useful.
I think it'd be worthwhile, Colin, taking it outside of the meeting, but I would certainly be very interested in what the outcome is, if you do, please.
Thank you, Chair. I'll write to you, but in essence, it's our concern, isn't it? The Accident Emergency Department in Lincoln is soaking up all of the local asset. But if we then can't have access to it when a serious incident happens, and we have to go out with the UNHT Trust, that doesn't seem right at all, because the benefits are not being made to Lincolnshire people. But we'll follow it up. Thank you very much.
Yeah, just to come back on that, so it wouldn't have been a trust decision why that would have happened. It would have been an ambulance clinical decision on the ambulance. So I don't, we'll look into it, but please be assured it won't be because Lincoln have turned it away, because that's not how it works.
Okay, thanks, Colin. And as I say, we will look into it. I'd be very interested to know what's gone wrong there, but thank you. Okay, I've got Councillor Cleaver next, please.
Thank you, Chairman. I noticed that you're going to come back in June and talk about the Lincolnshire Urgent Treatment Centre strategy. And I wondered whether the work you've done reviewing 23-24 is going to feed into that as lessons learnt as to how you might change the capacity of the system across the county.
Yes, so the Urgent Treatment Centre review is we've reviewed all of our current urgent treatment centres. We've looked at the needs and the demand and where it's going, both in terms of GP out of hours, but also in-hours services. And then that will produce a report that gives some recommendations to us about what we need to do in the future. So we know that one of the things we've been trying to push in Lincolnshire, for example, is people to call 111 first, because a lot of people that go to a UTC with something that they could have been booked at in a UTC at a later date. So it's fine that they go there, that's not in question, but they didn't need to go now, and then they have an elongated wait. And then we're having to sift through the urgents and the non-urgents. So for example, it's that sort of thing that we will pick up in the data in terms of what are people presenting with, what's actually the need in the areas across the county, and then that will produce a report. So obviously, as I explained previously, that report has been a bit delayed because of the industrial action. We're having to keep divert teams into supporting the development of the plans for industrial action. We're a little bit behind where we expected to be, but it certainly will cover what you're asking.
Councillor Mackinson-Saunders.
I just wanted to come back on 111, if you could explain it to me. I went to a pharmacist with a problem. A pharmacist said, go home, phone 111. I had a pain control nurse phone me up with 20 years experience, lovely lady, and she gave me a list of things I should be asking for. I went to my local GP practice and they said, oh, what rubbish, and gave me 100 paracetamols. I couldn't see what the point of somebody who was a specialist giving me advice. So I just was going to ask if you could explain the role of 111 properly, because I was aghast at the way I was treated.
I mean, I'd happily look into that for you, so we can listen back to calls and we can understand exactly what happened. The bit about what happened with the GP, we'd have to pick that up separately, but we certainly can understand what happened in the 111 element of your pathway. So essentially 111, that's our single point of access, really. So if you're not sure, and you don't, even if you are sure, it's best to call 111 unless you've got a genuine accident, or clearly if you're having a heart attack or if something else is happening, then you go straight to an ED, don't you? But if you're not quite sure, then 111 is your first port of call, because they can offer treatment and advice over the phone, like this sounds like they did with you. They can book you into a GP appointment. They can book you into an urgent treatment centre. They can refer you to the local clinical assessment service, which is what happens with quite a lot of the 111 calls where it's not obvious what needs to happen. Then they can refer you to the local clinical assessment service, who have access to all of the services in Lincolnshire and can work out what's next. The reason we want people to what we call talk before you walk to an urgent treatment centre is because in doing that, if they assess you and say, yeah, you need to be seen, we've got an appointment at 5 o'clock, you can come along, have your appointment, and you're likely to be on time. If you just turn up, then you're just going to be sitting waiting with everybody else. So it's trying to manage the flow of demand in urgent treatment centres better than we currently do it. So their role is really to triage. So they do a non-clinical algorithm, and then they'll also pass you through to clinicians where appropriate. And then if appropriate, they'll pass you to a Lincolnshire clinician, which is what happens for the majority of ours that need clinical assessment. They come through to the Lincolnshire service.
I didn't actually have a problem with the 111 service. I had the problem with the next bit along, which seemed stupid given that the person had a lot more experience than the person I ended up seeing.
Yeah,
and it was so
again,
frustrating.
Very, very happy to look into that, because that's not how it should be working, but we'd need to understand what the details were.
Okay, Councillor McGee.
Thank you, Chair. Yeah, I'd just like to come in on that because I have a very similar experience that happened just on Monday. So I also think we need to communicate with patients better that you do need to phone 111 before you go to UTC, because it's not commonly known. But I knew, so I phoned 111 and I explained my symptoms, which were, I was like, oh, do I need to go to hospital? Do I not need to go to hospital? I'll phone 111. And they were very clear that I needed to see a clinician at my GP practice within an hour, because it was during opening times for my GP practice. And they did what they were supposed to do, so they triaged me very well. They realised that it could be a situation that escalated, you need to get in to see a GP quickly. They then contacted my GP practice, told me to phone my GP practice, and I did. And I got a message back going, oh, we haven't got any appointments. And then you're in limbo. And so, I'm quite forthright, so I phoned up and said, absolutely not good enough. If one person's triaged me as saying, I need to see somebody. So then they're like, no, we'll leave you till the end of the afternoon. So they tapped me on right at the end and popped me in with a nurse practitioner who basically said, if you've got blood pressure machine at home, monitor it yourself. And if you've got any issues, go to A&E. So there is a disconnect between what happens in opening hours of your GP practice, and that's because of the pressures on GP practices. But if there is some sort of collaborative work that needs to be done, because if you've got clinicians assessing you as needing to see a doctor, then you should be able to see a doctor, because from a patient perspective, that leaves you quite worried, because you've got one person saying you actually do need some treatment or to be assessed, and another group saying it's not that much of a problem. And so then you're left wondering, well, do I actually just go to hospital because now I'm concerned? So I think some work needs to be done, one, with educating the public on using 111 effectively and what to do during opening hours of your own GP practice, and also some work done with the GP practices to recognise that if 111 say something needs to be done, it probably needs to be done.
Yeah, thank you for that feedback. I think that's a really good point around the comms, and it's something we did a lot through winter in terms of trying to publicise that message, but it's really difficult to get out there to everybody, so we do need to think a bit more about what we do about that. But absolutely take on your point, though, that if you've had a disposition from 111 that tells you this is what's needed, then you should have been able to get that appointment. So again, that shouldn't be how it works, and there is certainly quite a bit of work that's happening at the moment around the kind of trying to work with primary care networks and our community services and other colleagues to improve the pathway, and that certainly sounds like an example of where it could have worked better. So thank you.
Just one more quick question about the virtual wards, because I had a look on the website and they look really positive on paper. I just wondered, are they suitable? So a couple of questions. There's lots of remote monitoring that goes on to check to see where somebody's at. Is that dependent on the patient relaying that information to clinicians? So do they need to take their own readings, upload their own readings and send them? And if that is the case and it's reliant on the patient, if you have a patient who lives alone, are there some sort of fallback system? So if there was no readings sent, that would lead to a telephone call, somebody checking in, somebody making sure that person was okay?
Okay, thanks. Great question. The virtual wards are really exciting, and why they're also exciting is they're personalised. So actually, if it was yourself, if I'm so bold as to make a judgment, that obviously the empowerment and the personalisation around your care and the way you would upload your monitoring, you might have an Apple Watch, lots of other makes on the market, I know, but you can therefore plug that into the system. If it was my mother, that would not necessarily fit as well, and she doesn't have that sort of kit. We're also mindful for those individuals who live in IT connectivity, more rural, deprived areas. So we've also done a lot of work to think through how you can still be on one of our virtual wards, but not necessarily have that level of connectivity. So it's very personalised, often for our more frail elderly individuals with a long-term condition. They will be receiving other partners' care, as in local authority or support in different ways, and therefore we can bespoke how that monitoring links in. Also, there is obviously the checking, lots of regular checking. It is like a virtual ward, so it's not so remote that you don't hear from anybody from days on end. So, but I think what's really exciting about the virtual wards is they're so personalised to your individual needs, how it fits with your family and that as well. Thank you.
Okay, thank you. In which case I'm going to close the debate down now and I'm going to move to a proposal. I propose that we note the many positive improvements over the last year and for meeting the 4-hour accident and emergency and urgent care standards, but acknowledge the Lincolnshire system has much more to do to improve the emergency and urgent care pathway for patients. To also schedule an item during the autumn on the Lincolnshire systems plan for the 24-25 winter, and to thank our presenters. Do I have a seconder to that proposal? Thank you, Councillor Hayes. All in favour, please show. That's supported. Thank you. In which case, we'll move straight into agenda item 7, United Lincolnshire Hospitals General Update. This item was circulated as part of the agenda pack on pages 81 to 90. As set out on the first page of the report, this report covers a broad range of ULHT activity and developments. And once again, I'd like to hand over to our presenters, Julie Frake-Harris and Claire Raybould. Thank you.
Thank you ever so much, Chair, and thank you for the privilege since being asked to step into the Chief Operating Officer role for both LCHS and ULHT to be able to present this. Also, thank you for being very clear around the, I think, circa 10 items that you've asked me to update on. I obviously won't read the report because I know you will have all done that already, but I will just pick out some of the key items and then obviously happy to move to questions. So the first couple of sections are very much around our data and our activity. You can see from a productivity perspective, notwithstanding the fact Claire's already done a very deep dive into our unplanned activity, this takes us through our planned activity. We are really pleased to be able to report that the number of patients who are waiting in the region of 78 weeks for treatment, which is an incredible amount of time that none of us would want to wait. We've been able to absolutely minimalise that, and we're on target for 78-week waits to be a thing of the past, and doing some great work supported by the ICB in order to be able to bring our 65-week waits also down. So we've done some really great integrated work around that elective activity. CQC activity, as you will be aware, we've been supporting the delivery of our CQC action plan, and absolutely great to report that those outstanding areas we've now been able to close off, and I think that's really exciting for us to be able to move to a more positive delivery for our patients. Louth, there was an ask to make sure we were clear about all the services that are being delivered at Louth, and you can see that they're listed. I'm happy when we go to questions if there are any particular areas. Recruitment and retention, as you're all incredibly aware that we only deliver our services through our workforce. Our people are our greatest asset. We've been really focusing on reducing our vacancy factor, and I think the evidence is there, particularly in the unplanned pathway. It's being able to reduce our reliance on agency staff and increase the number of permanent staff and support those who wish to do bank shifts with us. I was only with a team before I came to be with you this morning, talking to one of our small teams, and the number of retirees that we've been able to support to come back on short contracts and therefore keep their experience. It's another part of that recruitment and retention work, as is the development of our international recruitment. We've been very successful both in international recruitment and our apprenticeship scheme in Lincolnshire. It's something we're very proud of, and we hope Lincolnshire is too. Storms Babette and Henk, not only did we get good at working through industrial action, we also got through highly experienced. In fact, I never thought I would be so experienced in coastal flows of tides and rivers and whatnot as somebody who is new to the geographical area. From a ULHT point of view, we did weather both those storms very well. From an LCHS point of view, we were able to support several of our patients who we did actually need to bring in because they were so vulnerable in areas. And so from a group whole pathway perspective, I think we were able to support all of our patients in a really positive way. As it was quite a tough time for that short period, wasn't it? Car parking. Section 7 hopefully covers the areas that were of particular interest, but again, when we move to questions, Chair, happy to pick out any areas that we haven't covered in the report. It is a really tough one in such a rural county to make sure that we are able to support our patients to be able to get to their appointments and not to miss any of their appointments. With the positive work around planned care, we've also looked at how we support our patients in making sure that the appointments are at the times that are best for them. Lots of that work sort of comes in line with, actually, if you are able to come in the middle of the day and that's easier for you, both from a traffic but also a parking perspective, we're working through those more bespoke offers, which I think is really important as each of our patient is an individual. Then there's the Lincolnshire Provider Review. This is something that we've obviously done, incredibly supported by our wider partner colleagues. And as you're aware, the development of the Community Primary Partnership, something we refer to as CPPs, is about making sure that all of our care is really linked up around both general practice, primary care, secondary care, and then the acute care offer. You've already heard and you're very well briefed on the ULHT LCHS group model, which we officially became a group on the 1st of April. And as you'll be aware, we now have a chief exec-elect ready to start on the 1st of July, which is exciting. Then the work around shared services. I think this is one, as public servants, we should absolutely always be able to develop the best value for the Lincolnshire pound, and that piece of work is very much focused on that. What I've just described is a colossal amount of change, and therefore making sure we do have the right support and development to make sure that change isn't stopping any service delivery while everybody works through what that looks like. So therefore making sure it's underpinned by a really good OD support network. The teaching hospital status application, we're still waiting for that to be formally moved through. So that is still the position, and I did check that there wasn't a change in that position before I came to present today. And I think I was really pleased to see that also Section 10, you wanted us to highlight particular good news stories, which, as you can see, there is a really long list, and they are also showing the great investment that we've managed to bring into Lincolnshire, both from a CDC, that's our Community Diagnostic Centre, new endoscopy services. I mean, it's great investment in our services. Even the electronic patient record is another really fabulous investment into the services that we can deliver. I'll leave it there, Chair, and I'm happy to take any questions.
Okay, thank you. Do we have any questions? Councillor Smith first, please.
Thank you, Chairman. Just before I ask my questions, Chairman, I'd very much like to congratulate all those involved achieving gold in the Defence Employer Recognition Scheme. With my VAPC hat on, Chairman, I know that is not easy to get at all, and it's quite rigorous and very time-consuming to do. Of the staff recruited across all clinical grades, as mentioned in the report, how many were UK grown and not from international recruitment? Secondly, Chairman, with regards to elective care and waiting lists, it is still a major problem, and it's something I haven't quite seen in my 30 years, and even something my mother hasn't seen in her nearly 60 years. She won't thank me for revealing her age to the world, but it's something she hasn't seen either. When are we going to clear these backlogs? Because these are having a real impact on people's lives. And I'll use a family example again. I took my mother to Nottingham at about 5 in the morning. That procedure didn't work. She now has to have quite a major procedure on her jaw, and till she has this procedure, she has constant pain in her jaw. So these aren't just niceties, these are things people need because they're having serious impacts on their quality of life as well as their medical well-being. So when do we have an idea of when these backlogs will sort of cease to be the norm? And with your indulgence, Chairman, one final point I'd like to make very briefly on car parking. Public transport for many, and certainly most of my residents, is simply not a viable option to get to Lincoln County, Boston, or to get to Grimsby. You might get there, you can't get back. One parish in my division has no scheduled bus service to speak of at all. And Keelby isn't much better, and it's the second largest settlement in my division, Chairman, which is why ULHT have such busy car parks. So I think scheduling appointments as best you can, and I appreciate, it's the National Health Service, you need the appointments when the appointment is by and large, we can't please everybody, but trying to work around that is very difficult, but I think it's something we need to do, because every time I've been, I think with about one exception, Chairman, this has been from 12 o'clock, from 9 in the morning till last thing on an evening, it's heaving. And if you can't park, you can't really have your appointment, Chairman, because you've got to be able to park. Thank you.
Thank you very much. Thank you for those questions. I think that was 3, so I'll take them one at a time if I've got that right. From an international nurses recruitment perspective, I'm absolutely comfortable to get the exact numbers, but we're in the region of about 100 that were. So it's a fairly small percentage of international nurses. We've done a really good pipeline work around our apprenticeships and developing more local workforce, but we certainly need to be able to make sure that we've got a mix across in order to be able to get the maximum number of staff wanting to serve here. Planned care, I absolutely agree with you. We don't want any of our patients waiting longer than they need to. So we are absolutely on target to be down within 52 weeks at the end of this year. That still feels a very long period of time to wait. And for us, that's why we're looking at our referral and our outpatient criteria in order to make sure that individuals don't wait on a waiting list longer than they need to when potentially there was an alternative level of care. So I feel that with the Integrated Care Board support, we're in a really good position to make sure that we're working through those backlogs. We have the right amount of capacity, and I think regionally we actually sit in one of the most positive positions. So I realise that's not good enough, but our patients are most certainly not as waiting as long as others, but we want to do better. Car parking, we're doing a big piece of work around what do you actually need to come to an acute hospital site to be served for, because I think that's part of this solution. I don't think it's necessarily having any more car parks that it's so far to walk from one car park to get into your appointment. That's another problem in its own right. It's about making sure we've got the maximum number of satellite opportunities across the whole of Lincolnshire, and that very much links in as well to the community primary partnerships work and the work that we're doing as a group, because of course we do now have a lot more sites that we're able to move our services through to. It absolutely links in with the philosophy of care closer to home. because that feels very much like where we should be looking to that real step change in our model. Thank you.
Okay, I've got Councillor Cleaver, please.
Thank you, Chairman. I'm pleased to see the item about the electronic patient record, but it reminds me that I think we were told 2 years ago, I have a recollection, that was a big issue, that the Trust was so far behind everybody else on actually computerising patient records that it was something that was urgent then. So although it's good news to know that you received approval, it'd be interesting to know who you had to receive approval from to go ahead with that. But given that it would appear that this is so far behind in terms of that important use of technology in this day and age, I wonder how urgently and how quickly the project's going to be completed.
Okay, thank you. You're absolutely right. Why has it taken so long? This is a national bid. It's part of a national procurement. So therefore, it's department that we've been working through that process with. It is also an incredible amount of investment. So you can imagine that procurement process is quite a long one, to say the least. But while we've been waiting for that, there have been areas we've been able to really improve: our maternity records, our electronic prescribing. So although this is the full electronic patient record, which we've needed to therefore get central approval for the investments and the provider of, we've certainly been able to improve other areas in the meantime. So I don't want you to think that we've stood still, because this is still really important that we're able to centralise electronically our patients' records to therefore be able to share in the most appropriate way in order to make sure that our patients get the most accurate care they can by that sharing of information, obviously with their permission.
Sorry, so by what date do you expect the project to be completed, please?
I'm afraid I can't tell you that exactly, because the procurement process is still finishing. So when it does, and we've got that okay, then absolutely, and I'm comfortable to make sure that's fed through if it's before the next time you ask me to come back.
I can't help push a bit further on that. I understand you can't give us, but what we're looking at, are we talking years, months, that I think would be more useful in rough ideas? Because as Councillor Cleaver rightly has said, 2 years ago for him, I think going back 6 years ago, probably even 8 years for me, it's been something that's been said will happen. So it's just trying to push it. Are we looking at it in the next 10 years, or where are we roughly?
I can definitely assure you it won't be in the next 10 years, but it's probably going to be in the next 2. But let me get that back, because also once we do procure it, the rollout process for it will take us months, and having had the privilege of doing this elsewhere, making sure we've got the organisational development and the cultural oversight is the way we'll get the best benefit out of that. So once we've got the kit, it's then about the how, which we will be paying the absolute utmost attention to.
That's hugely useful in itself, so thank you. Councillor Mackinson-Saunders, please, next.
Well, the computerised records are interesting because I think perhaps with Grimsby Hospital it makes it worse, because I live on the east side of the county. Nobody's computers ever seem to speak to each other. And so GPs can't access stuff that's gone on at Grimsby in the right way. And you just think, in this computerised age, it just seems extraordinary that we can't do these things. And there's a litany going on at the moment of lost blood tests, lost scans, and all the rest of it. I would have thought once you've done one and you enter it into your computer, somebody somewhere would have been able to access all of this information. But it does seem to be, I'm hearing more and more about that, which is strange. So something's not clicking somewhere. But I wanted to really ask you about Louth County Hospital, because I live in Louth, I'm born and brought up in Louth, and it is a source of huge local interest. I don't think you do yourselves any favours by not communicating better what goes on up at the hospital site. But it's a huge site. I don't think it's not up to the public to understand you're one provider and there's another provider. They just see the NHS, don't they? And they don't understand that you do this there and the other trust does something else, because they see a site which used to be thriving and they don't think it thrives anymore. And we've got one ward left after having a lot of wards at the hospital, and nobody can. And it's always, why is it run down? Why is it run down? What's happening there? So you need to get your PR people onto it straight away. But you need to, both trusts need to work together, because I understand community health services run stuff up there. But I looked at some of these things, and the specialty clinics, I didn't realise that some of those things were actually going on at Louth, and I always think I'm quite well informed. But I think you just need to get the message out that the hospital isn't it's perpetually, is the hospital closing? Or when is the hospital closing? Are there any plans to open any wards there again, etc., etc.? So I think it's yet again communication, isn't it? Thank you.
Thanks ever so much, and thank you, Councillor, as well, for the support in what, you know, the help around the comms discussion. So actually, Louth, we're just about to make sure there is an increase in the endoscopy department. That's nearly an investment in an extra £1 million going in there. I'm on it now, I promise you. We'll also be able to employ extra staff there, and in fact we have them in post ready to be trained up for the minute that the building works have finished. We've also been able to expand our diagnostics, and we're expecting to be able to treat an extra 1,200 patients at Louth as well. So thank you ever so much for the support and for the challenge to make sure that we're celebrating the real increase in activity at Louth. I will make sure. Thank you.
You catch her out then now, you'll be able to follow her through. Just on the patient record issue, so we do have a shared record in Lincolnshire, which does enable all of the health professionals to see everything. But I think what you might be referring to is there was a new system put in around, and it was particularly in the north as well. It was across the board, but it was about blood test results and pathology, X-ray results and things like that. And it definitely had some teething problems at the beginning of people being able to see what they needed to see, but also to refer to the right thing as well. So, but I understand that that's been resolved now. So if you do hear of ongoing issues, then do let us know. And it is difficult because the systems should all talk to each other, and that's partly why it's such a long process to get something signed off, because it's part of making sure that they can do that. But yeah, it's tech should be so much easier than it is, and we appreciate that.
Okay, I've got Councillor McGee next, please.
Yeah, hi, thank you, Chair. Really pleased to see on here that under other positive developments, we've got stroke services listed. So I can see that there's going to be some building work at Lincoln that's going to lead to an increase in bed capacity. And my first question is, how long is that going to take? So when are we going to see those beds? And is that going to have an impact for patients currently using any services there? But most importantly, an enhanced community rehabilitation service. So in my former life, I was the social prescribing lead for Lincoln North and the Gainsborough area. And there was a real gap in community provision in terms of, from the third sector, supporting people after a stroke. We had great support around dementia, actually, but very, very little for stroke. Parkinson's was sporadic as well. So there were several conditions that we really struggled to find community-based support for people. So to see that the NHS is now looking at this is really positive. And I just wondered, and I know we're going to be looking at stroke services later on in the year, but I just wondered what that enhanced community rehabilitation service is going to look like. Is that just more people or better services?
Thanks ever so much. I think this is something I'm really proud to be part of from a personal perspective as well. So the build, we're just working through that procurement phase. It's not going to be in the next year or so that we will have built it. It's a really big we're thinking it's several £1 million worth of a new build in order to get this where we want it to. But there's a couple of bits around absolutely improving the stroke experience and service across Lincolnshire. One, we're part of a national programme. We're one of, I think, 6 organisations that was selected to look at our thrombosis techniques and how we use that particular intervention through the emergency care pathway, and interestingly through alternatives through our same day emergency care as well as ED. So first, at the beginning of a stroke experience, we're absolutely at the front of looking at how we can improve that. And then from a community perspective, I think this is one of those absolute benefits of the group model, that we've been able to bring together both the acute and the community stroke clinicians. We're ring fencing 8 of our community beds to have extra skills on the wards on our community hospitals for stroke, and increasing the stroke expertise of the therapy input into the community hospital, therefore able to reduce your length of stay from your acute stay into your community hospital stay and then back to your home stay. So this is really exciting. It will uncertainly improve the experience and the outcomes of those who experience a stroke, absolutely. And sorry, I should have said as well that, of course, with the Louth experience, that the community services, we're now all one. So in fact, that whole interface of being able to improve the experience both at Louth, it's not them and us anymore. I'm a pronoun kind of person. It's all we. We're in it together. So I think that's really positive, and we've been able to bring that front and centre to the stroke experience.
I'm really pleased to hear all of that. And I just wanted to know, the work on improving the community rehabilitation side of things, will that continue regardless of the build? So obviously the build's going to take a long time, but are those services going to be enhanced and improved whilst you're waiting?
Absolutely, and we've been able to also advertise and start to recruit to joint posts. So I'm really excited that we will be able to follow a patient's pathway with continuity of care. That was one of the values we hope to bring. So that the build will be outstanding, but all the development pathway work we're starting, we're getting on with it now.
That's excellent. Thank you very much.
Thank you. I don't have any other speakers at the moment, so I've just got 2 questions myself. The first one is on page 83, the report states that head and neck specialties, gynecology and gastroenterology are the most challenged areas and make up the majority of the long waits. Can you therefore expand on what is being done to improve this, and are any other areas currently fragile or at risk of emergency action?
So firstly, Chair, we go through the patient level lists on a more than weekly basis with our ICB colleagues. And so actually this is an area we know a lot of detail about, and this position has actually improved since this report was written. It's our ear, nose and throat area, which is our biggest pressure point. And yes, we have made considerable changes in order to make sure we can keep on top of those waiting lists. Absolutely, this work across all our specialties has been done right down closest to where the work is done, and we have made considerable changes. I feel quite confident in where we are. It links to one of Councillor Smith's comments already around that waiting list. It's why we know where we'll be, is because we've done this with support down to speciality level.
Okay, then very finally, and I know you've alluded to this, but when do you actually think you're going to receive word of the outcome of the application for a teaching hospital?
It could be any day, and I did check yesterday, Chair, to check that I wasn't in a position to say anything different than what's in the report, and unfortunately we haven't heard yet.
Oh, that's reassuring in itself. I didn't know if we'd be looking months or, but you never know. So that's good.
It's on somebody's desk.
Excellent, thank you. In which case, I'm going to move to a proposal that we welcome the Trust's progress in the last year in eliminating waits of over 78 weeks and the plans for further reducing waiting times for elective care and the other Trust improvements over the last year, such as redeveloping A&E at Pilgrim. We will take updates, but I think we'll look into the individual subjects and see what we can pick up within the work programme. So, do I have a seconder for my proposal, please? Thank you, Councillor Martin. All in favour, please show. Thank you. That's supported. Thank you very much to our presenters for your attendance. We'll now move into agenda item 9, the work programme. Simon, your favourite part of the day.
Thank you, Chairman. If I can just ask the committee to look at page 92. We've got the items listed for the 15th of May, the people strategy, which is the overall recruitment and retention strategy for the county. And then we've got the GP provision item, which is going to pick up on, I think, the 2 GP practices. And if you're going to test me asking which ones they are that are rated inadequate currently, but there are 2 that we were told, and one, actually, is one in the announcements at the beginning? Yeah, sorry. Right. Yeah, so that will feature on the 15th of May. As has already been stated, we've got the urgent treatment centre strategy, which has been delayed, so that would have been the item today. And just stressing that the Grantham Urgent Treatment Centre is not part of that, so that's why that's listed on the 12th of June on page 93 as a separate item. And there are other things on the list. I suppose just going back to the previous item, which was a little bit of a it covered a number of things, and I just wondered if there are any things from that or any other items that the committee would wish to pursue at a later date. Thank you, Chairman.
Any comments, please? No? I'll take it as we're happy then, and I think we'll pull anything out, Simon, potentially, that we think might have came from the last item. But other than that, okay. If we're all happy, that brings the meeting to a close. Thank you very much for your attendance. Thank you.
Thank you very much, Chair. Well done.